All right, so this evening we'll look at oxygen transport and therapy. Actually, it should be oxygen therapy, but I felt we should also talk a little about oxygen transport, and then we'll dwell on oxygen therapy. It's important for us as anesthetists to understand oxygen transport, and oxygen therapy. And we're going to follow this outline. All right, the introduction, oxygen cascade, oxygen utilization curve, then oxygen therapy, complications of oxygen therapy, and conclusion. All right, we know that respiration is basically divided into two, the external and internal respiration. A more crucial part is the internal respiration, where oxygen that is breathing by external respiration is transported to the different tissues where they're used for, for metabolism. Once oxygen enters the blood from the lungs, it is taken up by the red pigment in the red blood cells, hemoglobin, all right, which binds to the oxygen and helps in transporting the oxygen throughout the tissue. Oxygen cascade is just to show us the various steps in the oxygen concentration gradient from the atmosphere to mitochondria, where it is used for cellular metabolism. All right, the different gradient helps, the transport of oxygen from the atmosphere, all right, to the mitochondria. From the atmosphere, the partial pressure of oxygen is about 159. And it keeps reducing to 150 in the trachea. Alveolar gas is reduced further to 105, and the mitochondrial level is between 4 to 20 millimeters of mercury. So these different oxygen concentration gradients helps to facilitate the diffusion or transport of oxygen from the atmosphere to the cellular level. All right, this is it. So oxygen appears in two forms in the blood. We have oxygen, which is dissolved in plasma. And this is important because this is what represents the partial pressure of oxygen in the blood. And only about 0.3 mils of oxygen is dissolved in 100 ml of blood at a PaO2 of 100 millimeters of mercury. And this follows the Henry's law, which states that of any gas solution, the concentration of any gas in solution is proportional to its partial pressure. So oxygen dissolved in plasma constitutes the partial pressure of oxygen that is recorded in the blood. The second form of oxygen present in the blood is the oxygen that is combined with hemoglobin. And combination of oxygen and hemoglobin occurs in 4 different steps, and the subsequent steps faster than the previous ones. And when fully saturated, 1 gram of hemoglobin contains about 1.39 mil of oxygen. So if you have an average hemoglobin concentration of 15 grams per DL, 100 ml of blood will contain a total of 20.1 mil of oxygen if you use the Hoffman's constant of 1.34. All right, so mentioned this before. We'll just go through it. There's a change in shape of hemoglobin as it combines with oxygen. And this change in shape, all right, helps to define the affinity of hemoglobin for oxygen. So the more oxygen is bound to the hemoglobin, the more the molecule's affinity for oxygen becomes. And this is what is referred to as the cooperative binding. The more oxygen binds to hemoglobin, the more hemoglobin has affinity for oxygen. All right, and oxygen, all right, hemoglobin also exists in 2 different states. We have the tense state and the relaxed state. When there's no oxygen bound to hemoglobin, it's said to be in a tense state. And at this point, it has a very low affinity for oxygen. But at the point where the first oxygen binds to hemoglobin, the shape alters into a relaxed state, which has a high affinity for oxygen. Important definitions: oxygen flows, oxygen content. All right, oxygen flows is defined as the total oxygen that is delivered to the tissues per unit time. All right, while oxygen content refers to the sum, the total of oxygen in solution, and that is carried by hemoglobin. So the oxygen flows is a fraction of oxygen content. Oxygen extraction ratio, for those of you who have worked with me in ICU, I like to talk about oxygen extraction ratio vis-a-vis allowable hemoglobin concentration of critically ill patient. So oxygen extraction ratio refers to the ratio of oxygen uptake to the oxygen delivered as expressed in percentage. The oxygen delivered is not all the oxygen that is delivered to tissue that is taken up by the tissue. So the ratio of oxygen taken up by the tissue divided by the oxygen that is delivered to the tissue refers to the oxygen extraction ratio. And it's normally about 1/4 of oxygen that is delivered. However, during exercise and and during stress, also, this oxygen extraction ratio can actually increase exponentially, especially when it has to do with the myocardial extraction ratio, which can go as high as 70%. Another important term to define is what we know as the oxygen saturation that we normally refers to, all right, which is the saturation of hemoglobin with oxygen that is measured using a pulse oximetry, all right, which is equal to the oxygen content of the hemoglobin, oxygen capacity of hemoglobin, all right, the oxygen content of hemoglobin divided by the oxygen capacity of hemoglobin. What does it mean? How much of oxygen is bound to hemoglobin over the capacity of hemoglobin to bind oxygen. All right, so at normal range, the normal range at 30 degrees Celsius at a pH of 7.4 with normal barometric pressure is between 9,700. So we expect that all the available spaces in hemoglobin should be should take up oxygen. And that's why we say that the SpO2, the oxygen saturation or arterial saturation of oxygen of hemoglobin is 100%. Now, I feel like that's a question important because this is what is used to calculate the partial pressure of oxygen in the alveoli, which is different from the partial pressure of oxygen in the arteries. All right. So it is given as partial pressure of oxygen in the alveoli equal to functional concentration of oxygen multiplied by the difference between the atmospheric pressure and the water vapor pressure, right? Which is subtracted, which is the PaCO2 is subtracted from it, divided by the what's it called? The respiratory quotient. The respiratory quotient is given at 0.8 at rest. So alveolar gas concentration helps to determine the partial pressure of oxygen in the alveoli. And from here, you can get the AA gradient, the alveolar arterial oxygen gradient. The oxygen dissociation curve, we're just reminding ourselves, this depicts the relationship between the percentage oxygen saturation of hemoglobin and the partial pressure of oxygen. And I told you that this reflects the amount of oxygen that is dissolved in plasma. This curve is sigmoid in shape and with the upper part being flat, which means that no matter how high the oxygen, the hemoglobin saturation of oxygen is, the hemoglobin saturation of oxygen does not change, in relation to increase in partial pressure of oxygen. So at this level, the increases in partial pressure of oxygen does not reflect in significant difference in hemoglobin saturation of oxygen. An important term here is the P50, which is the partial pressure of oxygen at which hemoglobin is 50% saturated with oxygen, and it is given as 27 millimeters of mercury at 26.5. All right, this is the oxygenation curve. All right, from partial pressure of oxygen to 60 to let's say 90, there's really relative no difference in the oxygen saturation, hemoglobin saturation of oxygen. So this is what we mean by the flat surface or the flat part of the oxygen dissociation curve. Now, if you look at this curve, we can have a leftward shift and the rightward shift. All right. The rightward shift means that there's reduced affinity of hemoglobin for oxygen, which makes offloading of oxygen to the tissues, occurring more. The leftward shift is when there is increased affinity of oxygen by the increased affinity of hemoglobin for oxygen. That means oxygen binds more tightly to hemoglobin, and there's less offloading of oxygen to the tissues. All right, so there are different factors that can shift the ODC to the right, all right, which means more oxygen being available to the tissues. An increase in hydrogen concentration, fall in pH, all right, a rise in PaCO2, a rise in 2,3-diphosphoglycerate level, and a rise in temperature. All this will shift the oxygen dissociation curve to the right, making oxygen more available for tissue metabolism. Yeah, Boyle effect is important because it reflects the affinity of hemoglobin for oxygen, all right, with changes in PaCO2. So with an increase in PaCO2, leading to acidosis state, all right, there's a low affinity of hemoglobin for oxygen. What it means is that hemoglobin gladly or more readily releases oxygen for tissue metabolism. So Boyle effect will cause a rightward shift of the oxygen dissociation curve. All right, the double Boyle effect is important because it relates more to pregnancy, where carbon dioxide diffuses from the fetal blood to maternal blood, and which causes an increase in maternal CO2 and a drop in CO2. So the net effect of this is there is more oxygen that is made available from the maternal to the fetal blood. All right, so this is where I come into. Oxygen is the commonest drug that is administered to critically ill patients. Or in the ICU, you have oxygen being administered to virtually everybody. So it's commoner to antibiotics, it's commoner to use of retroactive, it's commoner to the types of fluids. So oxygen therapy is important, all right? And it refers to the administration of supplementary oxygen above 21% to patients. And not only that, in following anesthesia and surgery where oxygen delivery to the tissues may be impaired, supplemental oxygen therapy becomes very, very indicated. And the aim of oxygen therapy is to restore the oxygen tension to as near normal as possible. All right, one of the commonest indication of oxygen therapy is hypoxemia or hypoxia, and they will just try to define it here. So hypoxia is reduction of tissue oxygen tension, all right, below the physiological level. All right, when you have a PaO2, all right, less than 11 kilopascal with FiO2 of greater than 4, not greater than 5, greater than 4. All right, you have hypoxemia. And the difference between hypoxia and hypoxemia is one refers to reduction of oxygen tension in tissue, which is hypoxia, and the other refers to the low oxygen tension in blood below the physiological level. The mnemonics of hypoxia can be classified basically into 4 major types that I call CASH. All right, we have cytotoxic hypoxia, anemic hypoxia, stagnant hypoxia, and hypoxic hypoxia. It's important for us to determine the type of hypoxia you're dealing with because it will impact on the therapy you want to institute. For instance, in hypoxic hypoxia, all right, the arterial oxygen tension is low, and this type of hypoxia responds well to oxygen therapy. Okay, and compared to anemic hypoxia, for instance, where the issue is reduction in the oxygen carrying capacity of the blood. all right? Obviously, you will increase oxygen delivery, oxygen concentration, but the only way you can do to deal with this is to also give blood, all right, so that you can enhance the oxygen carrying capacity of the blood. Cytotoxic has to do with the cellular poisoning, all right, which are caused at the mitochondrial level, all right. At this point, this kind of hypoxia responds very poorly to administration of oxygen. Stagnant hypoxia also has limited response to oxygen therapy because the oxygen tension is normal, oxygen carrying capacity of the blood is normal, but there's a reduction in flow of blood. It could be localized or global. At this point in time, oxygen therapy may have little or no effect on the oxygen tension in the blood. All right, there are different indications. I just brought this out for us to just take a look. But like I mentioned before, whatever indication, you need to first of all find out the underlying cause of the hypoxia or hypoxemia that the patient has. Oxygen sources, oxygen can be gotten from cylinders, all right? The medical gas distribution system, and they have two types of oxygen cylinders, the G and H types, and they can actually, the ones we see in theater, the one that is used for patient transport, resuscitation, and the oxygen cylinder that is attached to a receptive machine is the E type. So oxygen cylinders comes in different types, all right, and it depends on the area of use. A common source of oxygen is oxygen concentrator, which can be used at home, which can be used in recovery room, can be used in accident things, all right, and it's very cheap, it's very economical, and it uses the ambient air as a source of oxygen by applying zeolite granules which absorbs nitrogen from the compressed air, all right, and this is removed, leaving about 80% of oxygen to be delivered to the patient. Yeah, we have other types of oxygen delivery devices. We have the fixed performance devices, also known as the high flow delivery devices. All right, the high performance devices deliver known concentrations of oxygen to the patient. All right, they deliver the concentration of oxygen that you want to deliver to the patient. And this is important, especially in COPD patients with chronic bronchitis or bronchitis, where you want to deliver low concentrations of oxygen. Advantages include there's economic use of oxygen, all right, in the sense that you're not just giving oxygen that the patient does not require, all right, and it also gives you flexibility of controlling your oxygen therapy. Some of these devices that give you fixed performance oxygen delivery include the breathing surface at the base circuit, the chamber, oxygen tanks, and hold venturi, not venture, venturi mask. And these are color coded with specific fractional concentration of oxygen. The second type of oxygen delivery devices are the variable performance, also known as low flow. All right, the concentration of oxygen that is delivered to the patient here is variable, and it depends on the patient's respiratory effort and the flow rate of the device. For instance, the nasal cannula can deliver oxygen concentration between 24 to 40%. The non-rebreathing mask can deliver from 40% upward. But whatever it is, the oxygen that is delivered to the patient is dependent on the patient's respiratory effort and the rate of oxygen flow to the device. Now, examples of the nasal cannula, all right, you can see on the right of this of the slide, all right, the nasal cannula is a plastic disposable device, all right, usually consisting of two tips or one prong, or two tips or two prongs, which are about 1 centimeter long, and it's connected to an oxygen source. All right, the FiO2 depends, like I said, on the flow rate to the device and to the patient's respiratory effort. So it can deliver between FiO2 of 24 to 40% with a different flow rate between 1 to 6 liters per minute. In ICU for critically ill patients, I don't like giving nasal cannula, also nasal cannula more than 2 liters, all right, because of the disadvantages that we list. But part of the advantages of nasal cannula include it's easy to use, is well most tolerated by most patients, and patients can do other forms of physical activities or self-help, like patients can eat, drink, and pump. And in this, it's usually useful for long-term oxygen therapy for patients with COPD. But note these disadvantages that come with the use of nasal cannula. All right, they may cause pressure sores around the ear and nose because it needs to be attached. All right, and it's dry because it's not humidified, and it can cause nasal mucosal irritation with sores and all that. And it's not able to achieve high concentration of real oxygen in patients who have high minute ventilation. Most of the oxygen delivered to the upper airway are wasted, and for patients who are obligate mouth breather, this device is not suitable for them. We have the simple face mask, all right, delivers between 35 to 60% FiO2 with a varying rate of 6 to 10 liters per minute. Is useful for only a short time period of oxygen therapy of less than 24 hours. The partial rebreather mask, all right, has a reservoir bag which remains inflated during inspiration and expiration. It can deliver slightly higher concentration of oxygen, about 80%, but the flow rate must be kept at 6 liters per minute to prevent rebreathing by the patient. Advantage here is that the patient can breathe in air through the opening if oxygen flow is interrupted. You can see the opening here. All right, so at least the patient can get 1% oxygen from the atmosphere. All right, its disadvantage mainly is because it requires a tight seal and can be very uncomfortable for the patient. The non-rebreather mask, the difference between the two is that one, the non-rebreather mask provides a higher concentration of oxygen, all right, and with a higher flow rate. And secondly is that it does not allow rebreathing of expired gas because it has a two-way valve which prevents rebreathing of expired air. The bags and oxygen reservoir bank. Well, remember that it can lead to a buildup of CO2 and feeling of suffocation, makes it very uncomfortable and is expensive. Yeah, venturi mask is very useful device. Venturi mask is an example of high performance oxygen delivery device, all right, or high flow. It can deliver a no concentration depending on the color code that you use. It uses the venturi principle where an entrainment of a fluid, this time air, occurs through the side. This is the right, through the side, or an area of low pressure that is caused by constriction, okay, of the tube. Flow rates can range from 4 to 15 liters per minute, all right? And its most common advantage is that it provides the most precise oxygen concentration and provides a facility for humidification of inspired oxygen. Its disadvantages include discomfort. It can cause skin irritation. And for COPD patient, if you use this and the FiO2 is more than 50%, can actually cause respiratory depression. All right, the beauty of it is that it comes in different colors. All right, it comes in different colors from blue. I remember those days we used to have these mnemonics, beware of young wood girls. And the ladies used to say, beware of young rich guys, whichever way. All right. B is blue, all right, which provides the least concentration of oxygen, gives you about 24%, and can accommodate only a flow rate of 2 liters per minute. The beauty of venturi mask is that it helps in weaning the patient off oxygen and off ventilator, because you can, once the patient you want to do a trial TPs, you can start with a green cone, which gives you about 60%, and you can gradually reduce it. By the time you are getting to the blue cone, you are almost close to atmospheric oxygen concentration, and you can be sure that this patient can be successfully weaned off oxygen. So the color coding helps, and the difference in the flow rate and delivery of oxygen, fractional inspired oxygen, is due to the constrictions that is different in the different cones that are available. All right, this is just to remember our physics, the principle of venturi mask. All right, this is the tube, but there's a constriction here. All right, this constriction causes entrainment of air. All right, from the side. This is the principle of venturi mask. For the 24% venturi mask, the typical oxygen flow is about 2 liters, and that's the blue color, the venturi mask. All right. By the end of the day, because of the entrained air, it can actually give a total gas flow of 4 liters. I mean, 51 liters per minute. For the 28%, which is a flow rate of oxygen of 4 liters per minute, can actually give you a total of 44 liters per minute because of the entrained air from the constriction here. So at the end of the day, you have higher gas flow, all right, because what is delivered to the patient is now oxygen plus air through the principle of venturi. The TP is a form of high performance oxygen delivery device. It gives you accurate and precise oxygen concentration. It's used for weaning patient off the ventilator. It has, provision for nebulization and humidification. All right, and it's a very common device for weaning patient off ventilator. Oxygen tank provides you, more than 50% of oxygen that is usually used for neonates. All right, that require oxygen. All right, is a clear plastic shell that encloses the patient's upper body. Disadvantage is that it limits access to the patient, and you cannot use it during an emergency, especially that requires concurrent resuscitation with oxygen administration. Now, I want you to just familiarize yourself with this diagram, a table. All right, you can be given a table like this, and on the left side, you have the name of the equipment, and you can be asked what is the maximum flow rate that this device can tolerate, what is the fractional inspired oxygen concentration that can be delivered to this patient. So just make sure you familiarize yourself with this table, because it gives you the different flow rate, tidal volume, and specific flow rates of the different oxygen delivery devices. Yeah, it's important. Let's come to practical steps. And when you have ascertained that your patient requires supplemental oxygen therapy, number one step to take is you want to reassess the need for oxygen. Remember that oxygen is a drug, so it should only be given when it is absolutely indicated. Number two is that you want to also avoid oxygen toxicity. So you want to reassess the need for oxygen therapy and individualized care for your patient. So you want to ensure that there's documented hypoxia or inadequate oxygenation. And one of the ways you can do is use your arterial blood gas to measure your PaO2 and your PaCO2. Remember that this is the gold standard to demonstrate hypoxic conditions. Pulse oximetry may be used as a surrogate, all right, but it's a non-invasive method, but it has a clear correlation. And don't forget the disadvantage of SpO2 because of the accuracy that varies. In fact, it's less accurate, with SpO2 less than 80. All right. So, but ideally, an ABG should be obtained to document what is it called? The presence or otherwise of a person. Number two step is you want to ensure patency of the airway for the delivery of the oxygen. All right. If you want to do face mask, you want to do endotracheal tube or tracheostomy tube. You want to ensure that whatever route through which you want to deliver oxygen is patent enough. At the start of the oxygen therapy, you want to start with as high as possible. In fact, most times, especially for ventilated patients, you want to start with FiO2 of 100% for patients who have had cardiac arrest. And for those with hypoxic respiratory failure, type 1 respiratory failure, you want to go between 50 and 100%. But remember that after this, you want to obtain your ABG and you want to use the optimum FiO2 to ensure adequate oxygenation, and you want to prevent the deleterious effect of hypercapnia. Step 3, you want to monitor adequacy of oxygenation, and this is done with tissue oxygenation, not just PaO2. You are interested in tissue oxygenation. This is what will determine the adequacy of your oxygenation. You can be delivering 100% to a patient, but how much of it, and this is what we're talking about, the oxygen extraction ratio, how much of the oxygen being delivered to the tissue is being taken up by the tissue. And the way to do that is to measure your missed venous oxygen saturation. All right, your missed venous oxygen saturation mirrors the tissue oxygenation. All right, and this can usually be taken from the proximal pulmonary artery. But we know that pulmonary artery catheter comes with a lot of these disadvantages. It's not readily being used in most critical care setting. So we can use the central venous oxygenation saturation as a surrogate. So what you do is that you collect blood, and you measure the oxygen saturation from the venous blood from your superior vena cava. A low SvO2 or ScVO2 suggests that the cardiac output and the level of oxygenation are insufficient to meet the metabolic demands of the body tissue. So if you have a low SvO2, it shows that there's a low tissue oxygenation, which is irrespective of the oxygen that you are delivering to the patient. Step 4 always is to understand that there are risks involved in oxygen therapy. All right, oxygen toxicity is likely in an ICU patient when you are giving more than 50% FiO2 for longer than 36 hours period. So you must ensure that the following precautions are therefore followed. Now, number 1 is you want to use the lowest possible FiO2 that will maintain tissue oxygenation. Number 2, you want to also ensure that you use your lung recruitment maneuvers, for instance, PEEP. And those of you who have worked with me in ICU, I like the word Philippe, all right? Philippe is very important as your lung recruitment regimen to ensure that you get maximum or optimal oxygen delivery with the lowest possible FiO2. Then you want to regularly monitor for manifestation of oxygen toxicity in your patient. All right, complication of oxygen therapy, you know me with mnemonics, FARMLAND. So FARMLAND, don't start with the F, like I tell most of my students. F stands for fire, and also means combustible, supports combustion. All right, and we're going to look at it here, the FARMLAND. Oxygen is a highly combustible gas. Although it does not burn spontaneously or cause explosion, it can cause a fire if in contact with an open fire, open flame, or electrical equipment. So absorption of telectasis, all right? When you have large volume of nitrogen in the lung being replaced by 100% oxygen, all right, which is extremely soluble, you can see that most of this blood diffuses quickly into the pulmonary vasculature, and there's no enough gas left in the alveoli to maintain patency, so it leads to alveoli collapse. Okay, we have the retrolental fibroplasia in neonates. All right, this is blindness from from the retina due to oxygen-induced vasoconstriction in the retinal vessels. All right, especially in premature infants. So when you give 100% oxygen or high FiO2 to neonates, there will be oxygen-induced retinal vasoconstriction that can lead to blindness. Myocardial depression, oxygen, ironically, can lead to myocardial depression. Then we have the Lawrence-Smith syndrome, which was first described by Dr. J. Lawrence Smith. All right, he noted, that the severity of oxygen toxicity increased with increasing partial pressure of oxygen, and that the effects were largely reversible. Okay. Note that pulmonary toxic effect of oxygen can arise after prolonged exposure to oxygen that is above 0.5 atmospheric pressure. Anemia, interestingly, oxygen is used to treat anemia, but oxygen can actually precipitate anemia due to production of abnormal red blood cell morphology with or without reduction in the circulating mass of red blood cell. All right, there have been quite a lot of reports on hemolytic episodes following hyperbaric oxygen therapy. So oxygen can cause anemia. The last one, the neurological syndrome, also known as the Port syndrome, all right, occurs at oxygen pressure of greater than 3 atmospheric pressure, and is characterized by convulsion, vision changes, ringing in the ears, nausea, twitching, irritability, and dizziness. And this is the step 4 of our oxygen delivery. You want to monitor for manifestations of oxygen toxicity. So a short list of signs of and symptoms of CNS oxygen toxicity is what I mentioned before here. All right, if you look at it there, the NCCF HDX. All right, the convulsion. All right, oxygen can precipitate a grand fissure. All right, which can occur, insidiously without warning. Vision. Affect vision, it can cause a tunnel vision or any other vision change. It can cause ringing in the ears, can lead to mild to severe or continuous or intermittent nausea. All right, it can lead to facial twitching. All right, and this is most frequent symptom that most of the time we don't usually pay attention to. So next time when your patient is on oxygen therapy, and you're having twitching of the facial muscle, that may just be an early sign of oxygen toxicity setting in. Patients on oxygen may have behavioral or personality changes. They become very irritable. All right, those are signs of oxygen toxicity to the CNS. They can become dizzy, all right, disoriented, or have vertigo. These are signs and symptoms of CNS oxygen toxicity that we must pay attention to when we are giving oxygen to our patient. Narcosis, carbon dioxide narcosis, which can actually lead to loss of consciousness and coma. So we can have oxygen-induced carbon dioxide narcosis, especially in COPD patients who are exposed to high FiO2. This can lead to irreversible coma and depressed hematopoiesis, all right, which can also lead to the anemia we mentioned before. I like this graph. I want you to take a look at it. It's a graph known as oxygen tolerance curve, all right, which we have the exposure time in hours, over the partial pressure of oxygen that has been delivered. All right. So at inspired pressure of oxygen at 2 atmosphere, for about 15 hours, all right, most of the time they will have both CNS and pulmonary toxicity. Okay, now they look at it also, they higher the, all right, they higher, what's it called, the pressure of oxygen being given versus the time, all right. We also tell you the oxygen limits for CNS and pulmonary, all right. So you should just look at this diagram or this curve and familiarize yourself with it. It's important for you to understand, what it means. So for instance, if you're going to give, what's it called, oxygen for 5 hours, for 10 hours, there are respective complications, primarily in the CNS and in the lungs. Okay, I mentioned this before, the NCCF, nasal congestion, all that. But I just wanted to, okay, how much oxygen is safe? Okay, don't give 100% oxygen more than 12 hours. If your patient is desaturating, require 100% of oxygen more than 12 hours, you are exposing the patient to oxygen toxicity. So you must look at other lung recruitment maneuvers that you must put in place. Don't give 80% of oxygen more than 24 hours. And no patient should have 60% of oxygen more than 36 hours at a go. All right, these are the safety limits of oxygen therapy. The goal of oxygen therapy, therefore, should be to use the lowest possible FiO2 compatible with adequate tissue oxygenation that is assessed by your SpO2, like I mentioned earlier on. Okay, let me, we're still going to talk about PEEP and CPAP during our lecture on mechanical ventilation, but the lecture schedule put oxygen therapy and PEEP together. So we just mentioned this, but definitely we'll talk more about it when we're talking about mechanical ventilation. But suffice to note here that PEEP, positive end expiration pressure, increases the end expiration baseline airway pressure, and it prevents alveolar collapse at the end of expiration. It's usually used to treat refractory hypoxemia that is due to atrial pulmonary shunting. It's indicated when it's impossible to achieve a PaO2 of 60 milliliters of mercury with an FiO2 of 60%. Okay, you are at FiO2 of 60% and your PaO2 is less than 60, you need to increase your PEEP, or where the estimated initial shunt fraction is greater than 25%. All right, the intrapulmonary shunt is greater than 25%. It's an indication to introduce PEEP. All right, what are the benefits of PEEP? It increases compliance. All right, the lung compliance by increasing the functional residual capacity. It helps to increase collapsed lung. All right, I can see. Okay. It helps to open collapsed lung, and it maintains PaO2 at a low and safe concentration of less than 60%. Like every therapy, PEEP also comes with its own disadvantages. It increases dead space, it increases the risk for barotrauma, and because of the increase in interthoracic pressure, cause reduced cardiac output and reduced oliguria, reduced renal perfusion leading to oliguria, and it can actually cause vasopressin secretion with an increase in intracranial pressure. So you must make sure that the level of PEEP you introduce is compatible with your goals. All right, CPAP, on the other hand, is a constant positive pressure throughout the respiratory cycle. All right, it has the benefit of improving oxygenation and also decreasing the work of breathing. Sometimes our patients have increased work of breathing, and when you apply CPAP, it helps prevent excessive work of breathing in trying to overcome, whatever obstructions may be there. So there are different types. All right, we have the different types of CPAP. We can have the BPAP. You can have one level positive pressure. These are the different indications as it relates to it. Most of the time, we have the preset EPAP, all right, where patient initiate breathing at EPAP and the CPAP machine augments. Then we have the bi-level PEEP where you have both inspired and the expired PAP, all right, positive air pressure is applied throughout. Okay, so this is a CPAP machine, and most ventilators can actually deliver a CPAP, but you need a CPAP mask. And most of these things we'll better discuss them during our lecture on mechanical ventilation. Interestingly, many of us are used to amble back, but maybe we are not familiar with the proper working. So I just put it here to remind us that amble back is a way of delivering oxygen to our patient. It actually means artificial manual bagging unit or bag valve mask ventilation. All right. Amble bag is artificial manual breathing unit. It's a handheld device that is used to provide positive pressure ventilation to patients who are not breathing adequately or who are not breathing at all. It can be used as a form of resuscitation. Indications include patients who are not breathing at all, patients who are hyperventilating with a respiratory rate of less than 8 per minute, patients who have gone into cardiac arrest from whatever cause, and free oxygenations during rapid sequence induction. All right, so familiarize yourself. I like bringing this diagram out at undergraduate level, but there's nothing stopping me from bringing it out for you. Just bring the diagram and ask you to label it. All right. Note that we have some disadvantages because you can hyperventilate the patient. All right. You can cause excessive gastric inflation with increased risk of regurgitation and aspiration. Actually requires an open airway because you can't amble back a patient who has an obstructed airway. All right, so this is just like what I showed you before. This is another table to show you the different delivery device, the application, the flow rate, the FiO2, and the remarks. Now, we can talk about oxygen therapy if we do not mention hyperbaric oxygen therapy, which is indicated in different conditions. All right. Now, hyperbaric oxygen therapy refers to delivery of oxygen at a pressure greater than atmospheric pressure, usually at a pressure of 1.5 to 3 atmosphere. All right. The Undersea Hyperbaric Medical Society has recommended 13 indications for the use of hyperbaric oxygen therapy. In cases of air or gas embolism, in cases of carbon monoxide or carbon monoxide that is complicated by cyanide poisoning, in case of gas gangrene, crush injury with compartment syndrome or other acute traumatic ischemia, decompression sickness, when you have cases of arterial insufficiency, for instance, central retinal artery occlusion, and it can also be used for enhancement of healing in selected arterial problems. In patients with severe anemia, intracranial abscesses, patients with necrotizing or soft tissue infections, patients with refractory osteomyelitis, patients with delayed radiation injury, seen as tissue or bone necrosis, patients with compromised glass and flaps, all right, and patients with acute thermal bone injury. These are the 13 indications of hyperbaric oxygen as recommended by the Undersea Hyperbaric Medical Society. All right, so here we are. Do we have questions and comments?